So what would be your choice for such a patient? Would you offer surgery? Would you offer them radiosurgery? And what are the outcomes? Because if we go by the literature, then we find that these tumors can be very well managed by both the treatments, right?
Ma'am, to complete the picture of the investigations with a 3.5 centimeter lesion, I would also ask for a tractography.
Right.
To see because rarely the facial nerve can be posterior to the tumor.
Okay.
Most of the time it is anterior.
Good morning. I am Dr. Tejinder Kataria, Chairperson Radiation Oncology at Medanta, Gurgaon. And today we are going to speak and request Dr. Ashish Kumar Srivastava, a senior neurosurgeon from Delhi, to tell us about the benign diseases in the brain that can lead to major problems for a patient and how they can be managed with either surgery or radiosurgery. Welcome, Dr. Srivastava, to our first session of podcast. And we are grateful to you for making time to speak to our viewers about these diseases in the brain, besides what the symptoms can be and also how you are going to manage the patients who present with difficult symptoms which are chronic and are not very readily amenable to diagnosis.
Thank you.
You're welcome. So, sir, we have a patient who is 56 years of age and she has been complaining of some hearing loss for the last few years, which has steadily increased in the last 6-8 months. In addition, she also has a feeling of swaying to one side, that is on the left side. So with these symptoms, can I request you as to what else should we ask the patient, or what could be the possible things that are going on with her?
If I may summarize what you have said about the patient. So, elderly lady, she's got a unilateral, painless, non-traumatic hearing loss.
Yes.
Progressive.
Yes.
And I believe that you have said the positive things, so no other associated problems are there except for mild subjective feeling of swaying.
Yeah, she thinks that she is not having the proper balance when she's walking.
Yeah. So with this, I would like to add a few things in the history, either by taking a direct history or by ruling out certain things, whether there are any eye symptoms, ear symptoms, hearing loss, any tinnitus or otherwise, and look for few things which are associated with this kind of a hearing loss problem.
So what could be the eye symptoms for her? Or associated
numbness,
symptoms?
Reddishness of the eye. Mm-hmm. Then on examination, certain findings in the iris and otherwise in the fundus. Then I would also like to see whether there is any residue of shingles on the face, and whether there is any other associated symptom with other cranial nerves like facial, trigeminal, and otherwise, or swallowing problems in that case.
So you mean to say that a viral infection like shingles can also in time present with this?
What I was trying to emphasize is that with the detailed history and looking for very specific points pertaining to the other cranial nerves, the other symptoms associated with various diseases which can produce this kind of hearing loss, we would be directed towards the lesion itself.
Right. So you have taken the history and you've examined the patient.
Yes.
And now, is there a differential diagnosis which you can probably give us at this point in time and let our viewers know that what are the probabilities for such a patient and how you will take the next step of trying to confirm or disprove a clinical impression that you have?
Sure. Detailed neurological examination would cover most of the things, especially the cranial nerves, and I will also look for cerebellar signs or signs pertaining to ataxia. After that, I would keep in mind that a progressive, relentless hearing loss, albeit slow, over a couple of years, would most likely point towards a slowly developing disease, and tumors would fit that category very nicely.
Okay.
And the point where this kind of development happens would be the eighth nerve in its course somewhere.
Could you also say that in case there's a hearing loss that you would like to have some audiometry done on the patient?
I'll come
or-
to the investigations.
Right.
So first we have grossly pointed out that it's the eighth nerve which is involved, and we have taken the history and done an examination to see the associated cranial nerves, 7th, 5th, 6th,
Right.
the cerebellum itself, the brainstem. The brainstem is important because long tract signs, weakness and sensory deficits. But that is little later in the situation where things have grown out of proportion. So once we have done that and we are pointed towards a slowly progressing lesion, tumor is probably the most common cause we would look for.
But since it's a chronic, insidious development, so it would probably be something which is not very aggressive.
Yes.
Not a malignant tumor, but it could be
We have
something
benign
which is of a
tumor.
benign
Yes,
tumor.
I was coming to
Okay.
that. So, as you said, it's a slowly progressive, painless, and not very aggressive.
Right.
So, it's a benign lesion, most likely. And so, we would look for the causes in that area where the eighth nerve is for a benign tumor. And the commonest tumors there are the acoustic schwannomas and then the meningiomas, especially in ladies, which you mentioned the patient is a lady, and epidermoid tumors. These are the three tumors which would be the common ones.
Right. So epidermoid tumors, would they not be presenting at a little earlier age if they are congenital or epidermoid cysts?
They would, but sometimes they can be a little tardive in their presentation. So, I always just describe this as a 1 kilogram sugar buying situation where you have 990 grams and the balance is still lifted towards the sugar, and the grocery fellow puts 10 grams and the whole thing comes down. So symptoms appearing is what we are dealing with.
Right, sir. Right.
So then next step would of course be, as you rightly said, investigations. And I would always divide investigations in two parts. One is pertaining towards the surgical preparation or the treatment preparation.
Okay.
And the other group of investigations would be pertaining to the specific lesion which we are trying to rule in or rule out as a disease.
Okay.
So I will leave aside the general investigations which we all do for a surgery or for further treatment. And pertaining to this particular, our presumptive diagnosis of a benign tumor, slowly progressive, the first thing I would get is a contrast enhanced MRI of the brain. Since we are considering the diagnosis of acoustic schwannoma or a meningioma, and of course epidermoid, I would also appreciate an angiogram while doing an contrast enhanced MRI.
Okay.
And of course, since there is a hearing loss, to prognosticate and to decide the type of surgery or the type of treatment, I would also like to do audiometry, both pure tone as well as word recognition audiometry.
Right.
Because these two have a bearing on the type of treatment we give and the prognosis later on. Apart from this, of course, in rare cases, if you are looking for a perineural advancement of a malignancy, which can also produce this,
Right.
a CSF examination may probably be needed, but not necessary.
But that would historically be available to
We
us.
have already-
That if there is
yeah.
a diagnosis which is pre-existing.
Yeah.
So in this case, we would
We
probably
would
not
not.
do it.
I was just trying to complete the
Investigations.
yeah.
Right.
So, by and large, we don't do a CSF in this kind of lesions. But yes, if there is a perineural advancement, then we would like to sort of see whether we are missing out on a perineural advancement.
Right.
But that's a very uncommon, rare situation.
Absolutely.
So once we have got the MRI, which will tell us the exact lesion, and then there are a number of features which you are aware, which will point out the differentiation between acoustic schwannoma or a meningioma, and the angiogram would tell us, in case of a meningioma, the type of blood supply we have.
Right.
Because this area being a little tricky and intricate anatomy, sometimes for meningiomas, pre-op embolization is required to minimize the risk of surgery and to facilitate complete removal or safe removal of the lesion.
Okay. So once you are through with your audiogram and the eye test of the patient, her MRI, and you have the pictures before you. So let's say that there's about a 3.5 centimeters benign growth which you see on the left cerebellopontine area, and you also said that you've asked for an angiogram, and you specified that the angiogram would tell us in case it's a meningioma, then how to go about planning the treatment for the patient. So your radiologist comes up and says that, sir, this is about 3.5 centimeter, not a meningioma, but an acoustic schwannoma. And there is some pressure on the brainstem, on the ipsilateral side, but she has some imbalance, and we are looking for some cerebellum, impingement, but that's not there right now. But there is definite extension of the disease within the acoustic canal. So going further, how would you approach this case, and what would be your recommendation for the patient? And let's say that her audiogram shows that although she has a loss in the her hearing on the audiogram, but it's not complete yet, and it's still serviceable, and her right side ear is fully functional. So keeping these things in mind, how would you proceed for her?
Ma'am, to complete the picture of the investigations with a 3.5 centimeter lesion, I would also ask for a tractography.
Right.
To see because rarely the facial nerve can be posterior to the tumor.
Okay.
Most of the time it is anterior. Secondly, the MRI would also tell you that this acoustic schwannoma is not part of a neurofibromatosis type 2 lesion, where you may have asymptomatic other lesions in the brain.
And also the contralateral acoustic schwannoma, which the patient has not yet manifested clinically.
Thirdly, the patient may be, you said it's an elderly lady, so she may have some underlying hearing impairment on the opposite side also.
Right.
So then, so that becomes precious hearing on the side.
Right.
And you have used a very important word for management and prognosis point of view, that is serviceable hearing.
That's right, sir.
And that has a huge impact on the kind of treatment we offer this lady.
In what way, sir?
Both ways. From your side, way of radiotherapy, and by my side as a surgical intervention.
Right. I would like you to elaborate on the two ways of treatment for such a patient, not only to assist us to overcome the symptoms she's having now, but also in future as to how to manage her life.
See, ma'am, now the tumor has grown to 3.5. So it does not fall into the category where you can do observations by serial monitoring.
Okay.
It is definitely a growing tumor.
Right.
It would have definitely grown more than 10 millimeters in a year, which is the cutoff point for this thing, or 2 millimeters per year is actually the cutoff point where you can stop, when you can just monitor. So let's say that considering everything, she needs a surgical treatment.
Okay.
Now the surgical treatment would mean a decompression / excision of the tumor, depending on its characteristics, which will be available on the MRI.
Okay.
Now things have changed, and it's a teamwork between you and me.
Right.
So the classical technique of complete excision, whenever possible, is attempted, but at the same time, literature shows that the results are not too bad even if you leave behind a bit of tumor. So what I am trying to point out is that we have a situation where we can remove the tumor by a retrosigmoid or an extended retrosigmoid craniotomy and tumor decompression / excision. And depending on the anatomy and the abnormal anatomy in that area, we may be able to take out the whole tumor or part of the tumor. So once a surgical treatment has been done.
So I have a question for you here
Yes.
before we move forward,
Yes.
that the surgery has been done. What about the tumor which is going into the acoustic canal?
Yes.
Would it be surgically amenable for excision? And if the tumor is causing a kind of pressure on the brainstem, in that case, you mentioned about the tractography. Would you allude to that before you take a decision, and also after the surgery, how much your anticipation is for the residual disease?
Couple of things, ma'am. One is that because of the hearing preservation being one of the objectives of surgical treatment or any treatment for acoustic schwannoma, one tries to save other cranial nerves as well.
Right.
And in most of the cases, now the expertise has come to a point that most neurosurgeons will be able to save the facial nerve, but 3.5 is a huge size.
Right.
So the chances of saving the facial nerve come down significantly.
Mm-hmm.
Then tractography will be assisted perioperatively by doing the monitoring.
Oh, okay.
Intraoperative monitoring,
So
in
you
which two things are
electrophysiology.
monitored. One, of course, you monitor the facial nerve.
Mm-hmm.
But if we are attempting hearing preservation, then a BERA is also required, right? So that will help us in hearing preservation. So these two things can be used to preserve hearing if it is possible. Although in 3.5 centimeters, it has been found that even if one attempts hearing preservation, long-term result, the hearing goes down after surgical excision. And the involvement of other cranial nerves is also affected. Lower cranial nerves may be affected, though very uncommonly. But facial nerve and trigeminal nerve involvement is that is the sensory nerve of the face and the facial movement nerve, facial for the public. So these nerves do get affected sometimes, and one has to plan accordingly.
So that's what I was wondering when you kept mentioning about the 8th and the 7th nerve, that we do have the 5th nerve,
Yes.
or the trigeminal nerve, which
Yes.
is in very close proximity to the 5th nerve. And in case a patient, she doesn't have any symptoms, despite this being a tumor, post-surgery, she may develop symptoms, and that would mean that she could have some kind of sensory loss on the affected side.
Yes, ma'am.
And would that also preclude her chewing or swallowing if the lower cranial nerves are affected?
Lower cranial nerves being affected, the swallowing part is affected,
Right,
and nasal regurgitation can occur and all sorts of things.
right.
The trigeminal nerve itself, if affected, whatever degree, can lead to numbness. And of course, its motor component may affect the chewing and this masticating part. But that's little uncommon.
Right, and you rightly said that you have intraoperative monitoring devices, and also you have the microscopic,
Assistance,
access
yes. Yeah.
to the area, and thereby you can preserve these
Yes.
nerves, and you would be aiming for a safe resection.
Yes.
Right.
So far as the internal acoustic component of the tumor is concerned, that is the tumor part which is going into the canal through which the hearing nerve goes out and goes to the ear. That component is usually taken out by drilling the acoustic meatus, or the opening where the nerve is going out. You can drill it safely, and you can sometimes excise that part of the tumor too.
No.
Right, but thing is that with the advent of supportive therapeutic measures which you provide, one doesn't chase the tumor so much,
Okay.
if I may say it surgically.
Right.
An attempt is made, yes, but you don't chase the tumor, because there's always a surgical risk.
I
And
understand.
so if at the point of time of surgery, if you have to leave a bit of tumor, one should leave it rather than take risks, because we know that the team is sitting behind supporting us, and they will take care of it.
So the patient has had a maximal safe resection. She's been able to preserve whatever hearing she had at the time of presentation. In such a case, since some tumor has been left behind, what is the time that you would ask such a patient to go for radiosurgery or meet us? How soon after the surgery is that recommended, or would you like to keep her on observation and wait for this tumor to grow back?
I will answer both those parts, ma'am. This has been found that a 3.5 centimeter, as we discussed, is a big tumor. It has already got a growth potential which is significant. So I would rather not wait very long. I would wait for surgical healing, and once the patient is healthy, it has been found statistically that the longer time you wait, 2 years, 5 years, and 10 years is the time when we do the prognostication.
Right.
By that time, the impairment may increase or the tumor may regrow.
Okay.
So one doesn't like to wait too long. as far as the surgical healing is as soon as the surgical healing is completed, जल्दी से उसको जो है बाकी चीज का benefit दे दिया जाए, so that you kill the potential of it growing again.
Thank you so much, Dr. Ashish. And I also would like to ask you, now let's flip the coin to a patient who has only 1.5 centimeter tumor and has minimal hearing loss, and she is of the same age group, no other symptoms, no cranial nerve deficit. So what would be your choice for such a patient? Would you offer surgery? Would you offer them radiosurgery? And what are the outcomes? Because if we go by the literature, then we find that these tumors can be very well managed by both the treatments.
Yes.
Right?
Ma'am, anything less than 2 centimeter. 1.5, of course, is the technical point which you are saying when we consider tumors to be small and with little less growth potential and all sorts of things. And you rightly pointed out the clinical picture, there is no other associated problem.
Right.
In this case, the ideal treatment would be a radiotherapeutic intervention.
Right.
And in that, you people have both stereotactic radiosurgery and stereotactic radiotherapy.
Yes, since it's a 1.5 centimeter tumor, it's
You
very
would like to
small,
blast
so
it.
we would like to do radiosurgery.
Yes.
And at Medanta, as we have a couple of patients from you who have been serviced and they've been given this radiosurgery treatment and they're doing well without any adverse effects on the other cranial nerves, so to say, and having had an operative procedure. So is there a message that you can give to our audience that these patients can benefit with radiosurgery, and the patients who have a higher tumor mass or are symptomatic, as to what would be the best way for them? So I think I would really appreciate that.
At the cost of being berated by my surgical colleagues, but what the science says is that the option of monitoring and the option of non-surgical intervention should be foremost in our mind, considering that it is a better situation and better for the patient. Leave aside finer nuances of statistics and long-term prognosis. For a 1.5 centimeter tumor with no other associated difficulties in the patient, perhaps and most likely a radiosurgery procedure would be far better and will be giving better results than a surgery. So one should hold back the knife. And with this, I would also like to tell the public, just because you have a small tumor, an MRI is being done by the neurosurgeon doesn't mean that you have to land up with knife on the skin.
Thank you so much, Dr. Ashish. It's been really an illuminating discussion with you, and also I have revisited my MBBS neurology training, after having had this discussion with you, and I'm grateful to you to have traveled this morning to speak to us and to our viewers about this malady of benign tumors in the brain that sometimes go unnoticed and may present, like you said, the tip of the iceberg, which finally brings the patient down. And I'm grateful to you for this.
May I, ma'am, take the liberty of adding one little specific point? That is that we did talk about the situation of neurofibromatosis type 2,
Yes.
in which there will be multiple lesions.
You did.
We like to hold back our knife because there are too many lesions. You can't go chasing each one of them. Sometimes it is better to leave them and let the radiosurgery take care of those lesions.
So for our viewers, we do get our situations where the patient may have bilateral acoustic schwannomas or multiple tumors, as Dr. Srivastava said. So there, if the patient has symptoms more on one side, we'd like to address that lesion first and subsequently wait for some time, maybe around 6 months, before we target the other one, so that we can preserve the function of the patient to the best possible outcome. So we'd like to thank Dr. Ashish Kumar Srivastava for talking to us and to our viewers about the benign disease which presents with insidious hearing loss, some kind of balance, at times a sound in the ear which is called tinnitus, or may be associated with other symptoms due to other cranial nerves. And he has taken us through the history taking, examination, investigations, and the appropriate treatment depending upon the site, the size, and the single or multiplicity of the tumors. Grateful to you, Dr. Srivastava, for making time and coming and talking to us.
Thank you, ma'am, for this privilege, and I hope the message is loud and clear.
Please stay tuned for our next podcast.